Our next speaker is Dr. Vardhaman Kankaria, who's the director of Asian Eye Hospital, Pune, and again, very versatile, impressive surgeon in cataract and refractive surgery. And he would be talking on corneal tomography and ASOCT, the key to selecting cases, preferred practice guidelines.
Thank you so much, ma'am. And again, thanks to Dr. Chitra ma'am for the kind invite. I'm going to keep it brief. Friends, we all know that from the time of RK, which was about a century ago, to the current generation of refractive surgeries, where we have the complete armamentarium of procedures which are available to us with variety of corneal refractive procedures, phakic lenses, as well as refractive lens exchange in selected patients. The success of refractive surgery still remains in the preoperative evaluation. It is of utmost importance that we reject at-risk patients and eliminate the possibility to the extent possible of the post-LASIK ectasia and plan the most appropriate procedures. And to do that, it is important that we actually meet certain basic eligibility criteria that we all are aware about. But the most important eligibility today remains the assessment of cornea to withstand and maintain the effects of corneal laser procedures, which can be assessed with the help of corneal tomography and ASOCT, especially the corneal epithelial mapping of current generation. We all know that compared to the topography, the corneal tomography gives us much better localized elevation map that helps us to detect keratoconus patients when they are in forme fruste or very early stages, and has many advantages over topography, and it has by and large replaced corneal topography as the assessment tool. Coming to the preferred guidelines for the tomography for me, basically these are some of the things that I look at. It is important to look at the K-max, which is your highest keratometry, and anything beyond 48 diopters, avoid corneal procedures for them. Uh, when it comes to the corneal curvature, the superior to inferior asymmetry, where inferior is more steep than the superior by 1.5 diopters, or when you have a superior steepening in which the superior is more than inferior by about 2.5 diopters, becomes one of the relative contraindications. It is important to look at the skewing in the center, as you know that any skewing of the axis more than 21 degrees or 22 degrees is suspicious of developing post-operative ectasia in these patients. Always look at the best fit sphere, that it is 8 millimeters, so that it gives you the best possible elevation map. Uh, Abnormal anterior and posterior elevation more than 8 or 18 microns is what is considered to be suspicious. And of course, it is very important that you look at the pachymetry of this patient. For me, I don't go below 500 microns for LASIK as well as for SMILE procedures. And for surface ablation, I have slightly more room. I go up to 480 or sometimes up to 470 microns for very low myopia. With the advent of Bailey-Ambrosio display, it has become even more easy and for especially newer refractive surgeons to identify this at-risk corneas. And as you know, Bailey-Ambrosio display has the regular elevation map, the basically what is called as the enhanced display, in which you are actually removing the central 3 millimeters of the elevation, and then you are getting a difference map. And it actually tells you like an idiot-proof system where it is at risk or it is not, if you look at just the color codes of the system. On the right side, you're looking at the corneal thickness spatial variations, where we already know that the cornea is thickest in the center, and it is thinnest in the center. It becomes much thicker in the periphery, and there is a gradual graduation of this thickness entity, and you can see that there is a standard deviation. So as long as your line is within that standard deviation, we are looking at a very normal scan. But whenever you feel that this is actually deviating from the standard deviation, you have to be suspicious. Again, now with the help of the BAD-D scores, it has become very easy for us to know which are the corneas which are at risk. The golden rules or the preferred practice patterns for me, for whenever I see a abnormal pentacam, I do not exclude them immediately. I take 3 captures with good quality and consider the median as the median image. I try to exclude the false positive and false negative by looking at variety of the factors that we have seen, and especially now also including the epithelial maps. Whenever the topographic astigmatism is less than 1 diopters, you have a patient with large angle kappa, there is a misalignment when you have captured the image, or there is an enantiomorphism. These are some of the things that can help you to dismiss the issue with the skewing of the axis. So if I have one abnormality which is moderate, if I have no risk factors at all, then of course surface ablation, SMILE, as well as LASIK procedure, all 3 of them are possible. Even if I see one mild to moderate abnormality in the scan and it is a low myopia, then I always go with the advanced surface ablation. And my let us say criteria for SMILE and LASIK remains the same. So I don't do smile for patients where I would not do a LASIK. And of course, wherever you have a 2 or more moderate or 1 high abnormality, you should avoid any kind of corneal laser procedure. So you can look at this scan. So basically, this is a very flat cornea where you would actually avoid a microkeratome LASIK, and my procedure in such patients will be SMILE, which is a flapless procedure. Now, this is a patient who is hyperopic. In hyperopic patients, I do prefer to perform a topo-guided femtolesic such as Contura. Again, this is a patient where you can see a very nice symmetric bow tie and high astigmatism of 2.50 diopters. Again, the procedure of choice is going to be topo-guided femtolesic procedure. And in this patient, where you have an inferior steepening, surface ablation, where you have a very steep cornea, again surface ablation, and where you have absolutely keratoconus suspect kind of situation where you can combine cross-linking with surface ablation procedure, which is called as PRK extra as well. But in all the abnormal other scenarios where you have a very thin cornea or abnormal corneal topography, you should always go for ICL implants. Very briefly, I'm going to talk to you about the ASOCT. Actually, the epithelial mapping is actually evolving as one of the very important adjunctive tools for the refractive surgery selection. As you can see, one of the amazing things about epithelium is that it works like a masking agent. So in the early keratoconus, you will see that when there is an early ectasia which is developing inferiorly, but you will still see that the epithelium is actually becoming thinner. Therefore, your tomography will still come normal. However, when the keratoconus increases, the epithelium will become thinner and thinner, and actually that is when your tomography as well as the epithelial mapping will become abnormal. Studies by Reinstein et al. Have shown that the epithelium is actually thicker in the superior versus in the inferior quadrant, and in the keratoconus it has an annular pattern where you actually have a very thin epithelium in the center. Can I just take a minute more, ma'am? Yeah, thank you. And it has the annular ring around it where it becomes thicker and thicker. And as the progression of keratoconus increases, you will see actually the thinnest epithelial area is becoming thinner and thinner, and the annular area is becoming actually much thicker. Now let's look at this example where you have a truncated bow tie here, and actually the cornea looks otherwise completely normal. But if you look at the epithelial scan, you will see that at the level of this truncated bow tie, you have a very thin epithelium. So this actually becomes a suspect keratoconus, and we should avoid doing a corneal refractive surgery on them. Otherwise, looking at only tomography, we would have actually gone ahead to do a refractive procedure. Against that, as you can see, there is a clear inferior steepening. However, if you look at the epithelial thickness, the epithelium is actually much thicker in that area. So actually here is the role where it is abnormal tomography, but which is actually shown to be a completely normal scan by the adjunct of epithelium. The epithelial scan also helps us to differentiate between keratoconus and contact lens related warpage. As we have seen, if it is a keratoconus, you will have the thinnest point which is coincidental with the K-max, area of the K-max, but when it is a contact lens warpage, in fact the corneal epithelium will be much thicker there. And the last slide is about this very nice study which is published by Randleman. They have looked at the epithelial maps, and they have seen in how many patients the refractive surgeon had to change their procedure of choice or completely exclude these patients from getting a refractive surgery looking at the epithelial map as against what they had decided before. And they have seen that in almost 30% of the patients, their decisions have changed looking at the epithelial map. Therefore, patients who were actually were not considered to be at risk, they were actually somebody who were keratoconus suspect, and the patients who were actually considered to be normal, they turn out to have keratoconus suspect features. And of course, ASOCT in post-operative time has the ability to look at the residual bed thickness, to look at interface fluid syndrome, as well as look at the epithelial ingrowth and its extent, and also to identify epithelial fistulas at the incision. So to conclude, corneal tomography today has become a gold standard to identify at-risk corneas, but the corneal epithelial mapping by ASOCT is gaining importance as a great adjunct tool, especially in borderline situations where you would like to really confirm your approach to these patients. Thank you so much again, ma'am. Thank you.
Vardhaman, that was an amazing talk. I did get interrupted identifying my next speakers, but I actually would love to hear it once again. Very good, very thorough talk.
Thank you so much, ma'am.
And Anaga will take a question first.
Yeah, excellent talk, Dr. Vardhaman.
Thank you,
Dr. Somshila, I wanted to ask you a question. Considering a case scenario, a patient comes to you for myopic LASIK, K-max is 50
You be with us
diopters.
as expert panel, Vardhaman.
Refractive error is -8 diopters and the pachymetry is 530 microns. Which procedure would you suggest? 530 microns, -8 diopters, and 50 diopters is the K-max.
Because of the high refractive error, depending on the AC depth, I would rather go with a implantable lens, a phakic IOL, for this kind of patient.
If there's
It's
an
8 diopters where you have a reasonably good RST and the pentacam is normal.
Yeah, so without going to very detailed
So
discussion,
the message that I want to
yeah.
send across is, on what basis are we suggesting this? What would be the risk factors if you go ahead with LASIK, considering that the RST, PTA is all normal?
what was the issue? I missed
The
that.
issue is that the ketometry is 50 diopters.
Oh,
And so
50.
50 diopters
No.
is the extreme edge of
No, no. Because the
bell
visual
curve.
quality gets distorted if you do that. So you should not get flatter than 34. You should not get steeper than
No, but
48. To the
this
best
is
of
not
my
going to
ability.
be flatter than 34.
No, no, in
It's a
general,
minor,
I'm just
I'm
giving-
saying for this specific case, it's a 50 diopter with a -8 myopia with a good pachymetry, where you're going to have a good residual stromal bed. You're within the confines of a good PTA. So why would you still go in for a phakic IOL? It's not even more than 10 diopters, it's 8 diopters. So the message that I want to send across is, what is the basis that you would ask for a phakic IOL compared to a LASIK?
Actually, she's myopia, we are flattening the cornea, no, Somshila. So her logic is, you're not steepening it, you're flattening it. So how do you believe it's going to compromise? Earlier days we're using microkeratome LASIK. That would be a surgical complication is expected in steep corneas. But this is going to get flatter. I didn't hear a question, only now I heard it. So she wants the answer why
can
you would
somebody
say that.
please give me a specific answer to this question?
So I'll just complete, and of course I think we are on the same
Yeah,
team.
Yes,
please.
yes.
So my answer to this is that pentacam, or what the preferred practice guidelines are,
Yes.
what should help you and guide you here.
Yes.
As per preferred practice guidelines, that ketometry is definitely out of range for what you, as per the preferred practice guidelines. So you can make exceptions. So without going to, so
Yeah.
if I want to sit on a podium and say, what are the preferred practice guidelines? So this is beyond the preferred practice guidelines. So we have to keep the patient in front of us and make a decision on case-to-case basis. But if I have this patient, finances is not an issue, and the AC depth is good, I have a patient who's going to follow up, my preferred practice for this patient would be a phakic IOL. People may disagree.
Sir, please, your opinion. Please, can you give me the logical, scientific explanation behind this decision?
First of all, I'd like to know the age of the patient. 50, if it's 30
Not
year
50,
old.
sir.
No,
30 years.
So if it's a
30 years.
30-year-old person with a 50 keratometry, maybe he doesn't have anything as yet, number one. Number two, the optical quality, the visual quality, when you start flattening the cornea for 8 diopters, is definitely going to be different than what the person has been used to with the Q values the patient has. The optical quality, I've done MTF studies on my patients for high. So as a standard practice, in my practice, any dioptric power more than 6.5, I am going for phakic IOLs.
So, but
That's
here
the
we are
standard
not
practice.
flattening it less than 34. Definitely there are going to be spherical aberrations
Absolutely.
in any kind of corneal based refractive procedures,
That's your
whether
answer.
it is 6 or 8. Now suppose it was 6 diopters. Would you go in for LASIK?
Yeah, maybe.
Sir,
But
suppose
that's
it was
that's a
6
protocol I
diopters.
have set. That's a
Suppose it was
protocol
6 diopters with a 50 diopter keratometry. Would you go in for LASIK?
We are not getting the answer. We'll go on to the next question because just a minute less than that. The other thing is, in relevance to epithelial thickness mapping, if the epithelial thickness mapping is showing hyperplasia, Dr. Somshila, and and the patient has come for an enhancement, so would you want to do serial maps to look for stability before you enhance this patient?
Yeah.
Or would you do it as a two-stage procedure? Would you just do a PTK, look whether that has taken care of the residual refractive error, and later consider doing a PRK?
So again, we're blurring the preferred practice guidelines. I think Vardhaman
Yes,
brought
yes.
in ASOCT, and that was his
Yes,
topic.
yes.
But I would just like to first clarify that ASOCT is not a must-have at this point of time for preferred practice to decide or not decide on refractive surgery. But it helps us in making those decisions, especially to detect posterior keratoconus, which you can see it better on the ASOCT, or to detect how much is epithelium playing a role. And of course, as you pointed out, in terms of refractive error which comes back, so is it residual, is it progression, or is it ectasia? So the epithelial mapping definitely has a very important role to play. So if we have to serially epithelial map and don't decide on just based on one map, because it could be just for that point in time, depending on the drying of the eye and many other variables. Once you have reliable map which serially you've seen is the same, then there are two choices. You could go in with directly with the enhancement because that's what the patient is for. I wouldn't do a PTK and then go ahead. When I'm very sure that it's epithelium contributing to the refractive error, I would go ahead and then correct the residual refractive error or the induced.
There are more relevant questions for discussions here, but I think one odd speakers may not turn up. So, hello, Dr. Dhami. I'm nice seeing you. Very happy to see you. I'm going to change the sequence of speakers based on the availability because there's a film festival going on and majority of my speakers are sitting there. And that's how, so I'm going to call her because he's phakic IOL. So I thought I'll finish hyperopia with Soundarya. So I'm going to